Hello, everyone. This is Chadi Alraies from Heart Trending. I'm interventional cardiologist at Detroit Medical Center. I'm really privileged today to be with one of the late breaker presenters, Dr. Elmir Omerovic, who is presented a very important study, which is long-term survival and revascularization outcome in NSTEMI with multivessel coronary artery disease, going analysis of PCI versus CABG. Very important topic. Elmir, thank you so much for being with us.
Well, thank you for having me.
So let's just start by what is the hypothesis of the study?
So I would like to start first by saying that observational studies are integral part of the evidence-based medicine, and we often forget it. We are primed to favorize randomized clinical trials to base our decision, and that's fine that we have to do that. But many times the data are not available from randomized clinical trials, and then we have to turn to the second best, in this case, well-conducted observational trials. So that's the starting point. And it happened to be that when it comes to revascularization methods, CABG versus PCI, in the field of NSTEMI, patient with multivessel disease, we do not have a dedicated randomized clinical trials that will inform our decision, and we can say, well, the question has been sufficiently researched, and we have a conclusive response to the question. So it remains unclear which revascularization method is best. We should prefer, in our guidelines, in our practice, giving the current evidence level. So that's the background and why we wanted to do this trial in observational setting.
Absolutely. And again, you have used the SWEDEHEART registry, which is a huge registry. So tell us a little bit about who are these population and the number that you analyzed.
Yeah, so the aim was to compare CABG versus PCI in all comers. So SWEDEHEART registry consists of several registries that we merge together. We can derive many thousands of different variables that describe patient characteristics, procedural, details. We can merge with the follow-up outcomes, mortality, myocardial infarctions, the pharmacological registry, what kind of treatments the patients have been exposed, and so on. So in a way, SWEDEHEART registry is unique because we have 100% coverage of the population. So, for example, when it comes to the PCI, we have a 31 PCI cath lab all over Sweden. So every cath lab reports every angiography and PCI that has been performed since years ago, since 90s, basically. And the same goes for CABG. So that's the unique from the epidemiological point of view when we do observational trials. There are no other, to my knowledge, country that really has a virtually 100% coverage. So that's one thing. And starting from there, so we said, let's perform observational trial. Let's select the patient with NSTEMI who have multivessel disease, and let apply something that's called target trial emulation methods that has been popularized many years ago, lately by Miguel Hernan from Harvard. So we use that methodology, which basically means try to emulate a randomized clinical trial with your observational data. Define your population, define your starting point when you are going to count the time, and when it comes to the endpoints that are time to event.
Yeah.
And then in order to make causal claims due to the inherent limitation of observational trial, we use something that's called instrumental variable analysis. So that's the background for the study. So we really paid attention to apply state-of-the-art statistical, inferential, causal inferential methods that will allow us to make stronger claims when it comes to causality.
Yep. That's really perfect. And again, as I mentioned, it's a phenomenal registry going back to 1990s. Uh, so this is again just to make sure for the audience, these are patients who have non-ST elevation MI, meaning elevated troponin or unstable angina. We do an angiogram, we find multivessel disease, and then the operator opted either to fix with PCI or refer to surgery and undergo surgery.
So that's where the instrumental variable analysis comes into. So I have a slide in front of me, and I'm just looking to it. So we have over 30 different hospitals, and they differ when you have a non-STEMI patient and you have a multivessel disease. So based on the treatment preference, traditions and everything between that. So we will have different preferences depending on which hospitals you are practicing. So in my hospital, we are kind of in the middle when it comes to the preference for PCI, but there are hospitals that are very, very, pro PCI, and there are some hospitals that are more kind of conservative. So everything else the same. We have a difference. The preference for PCI varied in Sweden between 55 to 92, and STEMI multivessel disease. Everything else the same. So that is something, that natural variance in treatment preference can be used through instrumental variable analysis approach to calculate something that's called local average treatment effect and so on, which gives us more, causal claims about the effects. What is, superior to what?
Great. So that's great. Let's dive straight to the findings. So very interesting. So
we had a population of around 57,000 patients that 26% or almost 15,000 were treated with bypass surgery, and 74% or 42,000 received PCI as a treatment for NSTEMI with multivessel disease. And multivessel disease was defined as more than 2 vessels or more, or left main. So that's the definition of the multivessel disease. And primary endpoint were all-cause mortality, long term. We had also secondary endpoints: myocardial infarction, stroke, revascularization, and heart failure. So when it comes to so there are some differences in the patient population, although applying this target trial emulation, when you exclude the patient that you will not include in the trial, patient with cardiogenic shock, patient with cardiac arrest, patient with malignancies, patient with low life expectancy, and so on. So when you apply that, so your table 1 will look rather balanced, and then you on top of that apply this adjustment methods. So the primary endpoint was favoring bypass surgery when it comes to long-term survival, with an odds ratio of 1.67. And then if you go on, but let me just stop there, because what is important here, when we have a hazard ratio, if we discuss it, between clinician as well as between physician and the patients, hazard ratio or risk ratio or odds ratio doesn't say much. But if we do something that is called restricted mean survival time, if we calculate it, so what is the on average the expected life prolonging effect of your revascularization method, then if we translate that into amount of time that you will on average gain if you do CABG versus PCI, it goes like this. If you are expected to live 15 years from your revascularization day, PCR CABG, then you will on average gain 6.7 months with CABG.
Mm.
So that tells you something. I will
That's a very very good.
Yeah, so it's but on the other hand, if you are expected to live 5 years or less, so you will on average gain 25 days. And it's an important I think piece of information that we can take it for us as a treating physicians, but also to inform our patients, and then obtain informed consent and let the also patient participate in the decision. So for someone, I don't know, 6 months will be rather substantial gain in life expectancy, but for someone it will not. And also, while we can perhaps agree that 6.7 months in the category with other important treatments that have been established in the contemporary medicine, like thrombolysis and some treatment for heart failure and so on, well established survival benefit therapies. 25 days are substantially lower.
Interesting. I mean, I never heard that such analysis. As you know, we know that is odds ratio and hazard ratio and relative risk. But this is, again, if you give us a very granular number in terms of if you expected to live beyond, you said 6 months or more, then CABG will give you some extra. But it sounds like
then there's one caveat to that. So we are, prone to cognitive dissonance, both patients and doctors. So it should not be interpreted as it's life expectancy is not the same as lifespan. So the mistake we do, patients and physicians, we think this 6.7 months is something that you put at the end of your life. It's not that. You should interpret it that it is 6.7 months longer, and the treatment or benefit starts tomorrow after your treatment, on average.
Yeah.
So that's an important distinction.
Absolutely. And did you adjust, or did you felt there is a difference in terms of what medical therapy these patients were on, and if that's kind of affected long-term survival in either group?
Yeah, so we did several models, and eventually it will be available, for thorough analysis when the paper is eventually published. So we did a number of adjustment in addition to instrumental variable analysis, which actually it's like an act of randomization. This natural occurring experiments in terms of variation between the PCI clinics in Sweden. So you actually by that randomize your patients as in randomized clinical trials. But then we put into the model a number of variables that are known confounders, among other things. Medication.
Okay, great. And so despite that adjustment, we continue to see that difference, right? Or in terms of difference in the outcome after adjusting into multiple variables, medication, other comorbidities, we still do, which is really a powerful. I don't think I never heard or seen any trials or kind of registry analysis kind of looked into this question, and with showing these findings, which is reassuring for us. Again, I mean, I think the most trial that we so far we practice from and implemented in guidelines still say peripheral disease, syntax score, intermediate or high CABG, or even with low favor CABG. If your syntax is, if you have left main, now with Excel and Noble, we don't know what to do. I'm assuming, did your findings or registry included left main disease, or this is purely multivessel beside left main.
Yeah, I have the exact number. So giving this, differences in the preference. So of course there were differences in terms of patient characteristic. For example, severity of coronary artery disease was by far severe in patient with CABG. So if it's a how many patients in terms of percentage had left main disease in PCI group, it was 9.2%, while in the bypass surgery group, it was 37.2%. And the same goes for three-vessel disease. Almost half of them had three-vessel disease, while 30% had three-vessel disease in PCI group. So that's that was the different expected difference, what will happen in clinics. But when we then did a subgroup analysis, and one of those subgroups were severe coronary artery disease, then if we look at the effect of method of revascularization through this severity of coronary artery disease subgroups, two-vessel disease, three-vessel disease, left main, then we could see that there were no difference between PCI and CABG in patients who had two-vessel disease, while that gradient increased the more severe coronary artery disease was, the better effect the patient had of CABG. So it's kind of in line what we have learned from randomized clinical trials. For three-vessel disease, the odds ratio was 1.6, and for left main was 2.2 favoring CABG.
CABG, okay.
The other important thing is if we divide the patient according to the ejection fraction, also the most effect was present was patient with ejection fraction less than 35%, and they had an odds ratio favoring CABG by 2.2.
Okay. Great.
Meaning that if you do, yeah.
Well, I think
meaning that 2.2, meaning that if you do PCI versus CABG, your risk will more than double with the PCI.
Interesting.
If you have ejection fraction less than 35% in multivessel disease, right.
And instant, yeah. Well, I think this topic is really becoming more and more interesting, and more we have able to answer this treat the patient the proper way, because we have more studies, and definitely this study will shed some light on this small cohort, large cohort of patients, but we don't know sometimes. Treat the culprit, stage the rest, put a balloon pump, call the surgeon. Especially if everything TIMI-3 flow. I think this is what I think is important. But what you just mentioned earlier is very important, is the variability of practice. We see the same thing here in our hospital, from operator to operator, but also from state to state. Everybody treat differently. So this will be a helpful guide going forward for this kind of cohort of patients.
I agree. I fully agree. And then you should also use this. I think what is important is that physicians learn statistics and participate in the analysis of data that we have at our disposal that are probably severely underused in all countries that they have it. And the more physicians are educated in terms of statistical methodology and can participate with understanding of the subject, the better we will have in terms of producing useful knowledge, right?
Well, again, thank you so much for your time, really, and congratulations for a phenomenal trial. We can't wait to see the paper in print, but again, it has been one of the featured studies at ESC Congress 2024 in London. Dr. Omerovic, really thank you so much for your time, and congratulations again for a great study.
Thank you, Dr. Chadi. Nice meeting you.